Ladies and gentlemen, good evening, good morning, good afternoon, wherever you're dialing from. My name is Krish Sai. I'm the Regional Vice President for TEOXANE Asia Pacific. And I'm incredibly pleased to bring you this topic of periorbital rejuvenation. The focus is anatomy and assessment, and we can really see the interest. We've got about 330 people on the line already. We have over 1,000 registered for this topic that has interest continually across the regions, Asia Pacific and Europe. So to I suppose, play to the galleries on this topic, we've got three international experts, Dr. Tyra Bajani Lynch from United Kingdom. You have heard her before in masterclasses, webinars, and live sessions at various congresses. Most recently, she was in Australia, and she did a fantastic job of sharing her insights and her experience. And we also have Dr. Raymond Woon, no stranger to us, from Hong Kong, international TEOXANE key opinion leader. Over the last 9-10 years, Ray has been giving us his insights into a number of topics into facial rejuvenation. And also joining us on the panel is Dr. Enake Jain, dermatologist from Indonesia. Very recently, she was in Malaysia sharing her expertise. So we've got three experts to showcase their views into the periorbital area, their expertise of clinical practice, how they see it, most importantly, the anatomy and assessment. So the way we set it up for you is short, sharp presentations. Dr. Tyra is going to come up first, and she's going to do a small lecture of anatomy and assessment, followed by Ray, who's going to come on and do some case studies into the Asian patient perspective, which is a North Asian. And then Dr. Enake Jain is going to come last after that. On the case study theme, and she's going to give us a flavor of the South Asians. We're going to see Tyra back again, and she's going to give her views on complications, I suppose, picking up and how to manage them. Very, very practical and gold to me. So it's a beautiful setup. All three speakers are going to then do a panel discussion and ask questions of each other. Before I hand over to Dr. Tyra to set up a presentation, I'm going to ask all the speakers to come online and show their face and say hello, just to make sure that audio and video are okay. Tyra, Ray, and Enake, can you open up your cameras and say hello to us, please? In the last 3 minutes, we had another 70 people join us.
Good morning. This is Tyra Bajani from the UK.
Fantastic. Hi, Tyra. Fantastic.
Hi, I'm Jane from Indonesia. Nice to meet you all.
Brilliant. Everything is working. We're all set to go. Tyra, you take the lead. You can start sharing your presentation and give us your insight into anatomy and assessment. We'll start with that. So need I say, your 15 minutes starts now.
So in the UK, it's morning. Good morning, good afternoon, good evening to you all. My name is Tyra Bajani Lynch. I'm actually an ophthalmic surgeon. So periorbital is my area of expertise. So I'm going to give you a whistle-stop tour, 15 minutes to discuss detailed anatomy. Some of you may have seen me in the press or on various boards and committees. I'm going to go straight through. TEOXANE have this unique and very practical approach to assessment of any part of tens to do before you press. So if you assess somebody correctly and you know the anatomy, you can predict the result. You don't get a surprise when you press the plunger and think, it's not quite what I thought was going to happen. That should never be the case. It's all down to how you do that first section. So,
Tyra, this is Chris. Sorry to break your rhythm. I think we're seeing a bit of a lag or a breaking up. Perhaps you want to switch off your video and go back one slide. Is that right? Yeah, if you can go back a couple of slides. just for the benefit of everybody, because we don't want them to miss the flow when you started. Is that all right?
If I stop my video.
Yes, please. And if you could go back to your introduction of ATP, I think that's probably where we lost the audio and the video. So that's fantastic. Thank you, Tara. So back to you.
So hopefully you can hear me. And I usually point to my face when I'm teaching, so you won't be able to see me do that. You'll have to point at your own face. So anatomy, technique, product, ATP. If you don't know your anatomy and don't do a correct assessment, you cannot predict what the filler is going to do. If you press the plunger, you have to know what it's going to do before you press the plunger. That is why anatomy and assessment is key. So, basic differences. We often talk about the 5-layer approach to anatomy. We talk about the structural layers, which is bone and deep fat. Okay, and then we talk about the mobile layers, which are superficial fat and skin. Okay, and the bit in the middle is the muscle or the If you're going deep to, so you can choose something a little bit thicker and a little bit more chunky because it's not going to move. But if you are going to go into those superficial layers, you have to choose something that is going to move naturally with the skin. Okay? This is what if you work up your face, pinching the skin, you'll have fat skin and fat skin fat. And when you get to the under eye area, you'll see that there is no fat, you're pinching just skin. And this is critically important because when you put filler in the subdermal layer, you rely on the fat that is sitting within fat to disguise its color and shape. So if you're going in the under eye area and you're going just underneath the skin and there is no superficial fat there, you are going to see the product, which is why in the periorbital area, we go deep. We go below the muscle where you may still have some fat, or at least that the product is not going to be visible. Changes as we get older. Bony changes, we know as we get older, the orbital rim enlarges. Diamond shaped, and you get a lip, and you get this loss of support to the medial suit because the bone is not there. Okay. Continuing with the aging of the deep fat, still structural, you lose suit, medial and lateral, and your deep medial fat compartment. These are structural parts of the face. You think of your face as a bit like a bed, your mattress is shrinking, and your base of your bed is shrinking. Okay. Superficial fat pads are the mobile layers. Interestingly, your superficial fat layer here, just under the eye, is quite small in some genetic races and shrinks as you get older. And again, if you're over the age of 35, if you run your finger along your orbital margin, you will be able to feel your bone with no fat over it because that superficial fat pad is gone. Overall, the loss of support of the deep fat, the dropping of the superficial fat means that the orbital rim bears, and you get this appearance of a large enlarging of the orbit. Obviously, there's also true enlarging of the orbit because the bone is also resorbing, but you will see it as the evolution of the tear trough. The other very important thing you need to know is that the skin is tethered here, and it is not tethered on the lateral aspect. So when this support is lost, you get a rotation of the skin. You get a drop to the lateral canthus, even though that is what creates this groove. So that's why if you do a surgical lateral canthal lift, you cut the skin and pull it, everything improves. because what happens is this drops down and rotates in. Okay, that's what causes this groove. There is actually very little natural fat in the medial tear trough. The groove is caused by a loosening of the skin and a redraping of the skin, not by a fat loss. So when we put filler in that medial nasojugal groove, we're actually putting it in a place where there isn't normally fat. And that's why sometimes we run into difficulty when we try and do it, and it doesn't always look normal or natural. The fact that there is no fat, deep fat is losing volume, superficial fat has dropped down. This is why an aged orbit, you can see the actual bony rim because there is no fat. All you've got is skin, muscle, bone. And you can actually see how that periorbital area is visible through the skin. Racial differences are important because what I've taught you there is just a general, but there are some specific things. So I'm going to talk, some of my colleagues are going to talk about the ethnicities that we have to think about when we're injecting. I'm going to talk mainly about Asian as in Indian Asian. So we call them Asian Caucasian. The bony structure between white Caucasian and Asian Caucasian is not that different. And when we talk about Far East Asian, the bony structure is visibly different. So Far East Asian and Western Caucasian or Asian Caucasian, you can see the difference in the jawbone, you can see the difference in the projection of the orbit, but the orbital rim is very interesting because the Far Asian female bone already lips out, even before it's aged. Western Caucasian is like this, and an Asian Caucasian sits somewhere in between. And this is important when you look at the genetic tear troughs that a lot of Far Eastern and Asian people suffer from. So this is a typical appearance of the under eye of an Indian subcontinent face, where they have a shadow even in a young face, and it's caused by the concavity of the genetically small sooth. So this medial sooth that sits, and remember, medial sooth does not sit at the medial aspect. Medial sooth, the lateral aspect of the eye. Lateral sooth sits near the lateral canthus. Medial sooth sits between the mid-pupillary line and towards the lateral canthus. There's no sooth here. It's just skin and muscle. Genetically, teenage years, skin, so you get pigmentation. Where the cheek is at its highest point, you get sun pigmentation. And as the skin thins, the darkness of the muscle is visible through the skin. So you get a darkness of the area in general. So I know one of my colleagues is going to talk about assessing tears in a dynamic fashion. I'm going to teach you a very basic tear trough scale by Barton. 0, absolutely no difference between the tear trough and the cheek. A grade 1 is a medial canthal groove. A grade 2 is a medial and lateral canthal groove. And a grade 3 is where you get a demarcation where the sooth has been lost. Patient pictures how that grading scale works. So this is a lady in her
Hi, Dr. Tyra. This is Jacqueline. Are you able to hear me? Yes, so I think at this point we're getting into a bit of a situation with the Wi-Fi connection from UK. So Dr. Tyra is right now not online. So maybe while we are waiting for her to come online, a gentle reminder to everyone that it is not your laptop that's having an issue. It's a Wi-Fi connection at source. And I also want to remind everybody that you can please feel free to key in your questions in the Q&A chat box and as well as the chat box itself to interact with our doctors. Dr. Ray, maybe at this point, you would like to come on and perhaps share your case studies and your assessment while we wait for Dr. Tyra to be back. So I pass the time over to you, Dr. Ray.
Okay, sure. Let me share my screen. So hello, everybody. It's my honor to be here tonight or this morning to share with you guys some of the cases. So for treatment of tear trough, for me, is one of the most challenging areas in the face. It takes a lot of time to master this region, not only the technique, but I think the assessment is far, far, far more important than the treatment itself. So identifying the right cases and deciding how and using which product to treat is essential. So let's take a look at this case here. A very young lady, 20-something, under 30, without any injections before. So just have 10 seconds or 15 seconds, take a look at different angles, and you should ask yourself a few questions when a patient like this comes in your clinic asking for a consultation. First thing you need to ask is, what is the problem? Okay, what is the problem? Second question is, how are you going to treat it? Is it a surgical indication or is it just a minimal invasive option for her? So if you look at her, very obvious, under the eye region, there's a very flat hollowing, okay? So the first question is, you have to ask yourself, is it a combination with tear trough or a muscle problem or a fat problem, or is it a tear trough problem in combining with a mid-cheek problem? Okay, so if you look at her side view, it's very obvious that apart from a tear trough problem, you can see she has a very, very atypical Asian flat mid-face flattening there, which is a congenital for her because she's such a young age. It's definitely not a problem due to aging, okay? So firstly, you need to understand she has a combination of a tear trough and mid-cheek problem, okay? So the second question you need to ask, how am I going to treat her? Am I going to take away with just a tear trough injection or with a mid-cheek injection? So for this particular case, I treated her mid-face together with her tear trough, okay, in order to maximize the result, okay? So if you look at the anatomy, there, especially at the region under the eye, actually tear trough, when we talk about the SOOF and the deep medial cheek fat, is actually very, very closely located together, okay? So it's just a thin, very thin septum separating what we call the tear trough area together with the mid-cheek area. So it makes sense for you, in order to treat the tear trough and the mid-cheek together, is actually pretty much the same region, okay? So you have to understand that. For some doctors, especially beginners, they separate these two regions to in the distance. So if you treat the tear trough, okay, but sometimes by mistake, you're actually injecting into the mid-cheek, okay? So I'm sure most of you have had cases where you injected the tear trough, but then there's no improvement, but it's actually a step creating under the tear trough. I'm sure most of you guys, when you first counter a tear trough problem, you have experience with this. After injection with a soft filler, you don't see a visual improvement, but rather you have a worsening of the tear trough, right? So most of the time, this is because this is due to wrong placement of the product, okay? So you're not injecting high enough, okay? You're injecting into the mid-cheek. That is a common pitfall of treating a tear trough. So for her, I treated her mid-cheek together with the tear trough, okay? The sequence of treating these two neighboring regions, I will always treat the mid-cheek first. So you have a volume under the tear trough. You have some lifting from the mid-cheek. That would have a partial improvement to the tear trough above that, okay? So then you touch up with Redensity 2 into the tear trough area, okay? So this case, I've injected 2 cc of RHA4 in the mid-cheek both sides, okay, each side, 2 cc mid-cheek, and then 1 cc of Redensity 2 and 1 cc of Redensity 2 into the soothe right under the eye area, into the tear trough. So this is a combination of treating the mid-cheek together with a tear trough, okay? So again, I think it's the most important thing to tell the difference between what is a tear trough, what is an eye bag, and what is a muscle problem. You have to differentiate between the etiologies, and then that leads you to choose the right technique and the right method for your patients, okay? So in another view, you can see obvious improvement, not just to the tear trough, but the mid-cheek as well, okay? So you have to come up with a holistic approach to your patients. So second case, this is again, a very, very common mistake for beginners, okay? Even especially for laymen. This lady, actually, she came to my clinic. She told me she had a really deep tear trough that she wants to get rid of, okay? So first thing you need to ask yourself is whether that depression is really a tear trough, okay? So you have to understand, as I repeatedly stressed, not all depressions under the eye are tear troughs. A depression under the eye can be a tear trough, or under any elevations. So elevations could be a muscle problem or an eye bag problem, could be resulting in a depression, okay? So you need to understand that. So this is a good case to show you this particular depression is due to a muscle problem, okay? So if you have mistaken that to be a tear trough, where you have advised this patient to undergo a filler injection, what you're going to result would be no improvement, and then the patient is just going to complain, okay? So if you know that this is a muscle problem, the correct treatment would be a neuromodulator instead of an X-ray filler, okay? So this is the photo right now on the right side, is I've injected a little bit of neuromodulator to treat the muscle, but at the same time, I have injected a little bit of Redensity 2. Why? Because this case have seen the salesperson first, okay? So in the area that I work in Hong Kong, especially Southeast Asia, in our clinic, apart from nurses and doctors, we have these sales consultants. So where the patients will see the sales consultants first, and then the sales consultant will advise some treatments, and then they will take the credit card, swipe it, okay, and then go to the doctor for the treatment. So this particular case, she has seen the sales consultant. The sales consultant told her, yeah, you have a tear trough. Let's go for Redensity 2. Swiped credit card, okay, and then came to me. So in order not to disappoint the sales and also not to disappoint the patient, because not only herself thought it's a tear trough, she has been reinforced by the sales consultant. This is a tear trough problem, okay? So apart from the neuromodulator, I injected a little bit of Redensity 2, okay? So this is the end result, whereas the neuromodulator result kicked in, and then I did a little bit of touching up, really, really high up, deep, just under the orbital rim, okay? So this is the final result, but I have to admit, the result, the majority of the result is coming from the neuromodulator, not from the Redensity 2, okay? So this is a good case to demonstrate you need to differentiate the different causes of any elevations or any depressions under the eye. So for the tear trough, I think teaching it over a webinar basis, I think is a good way. Is the only region that I think is a good way to teach through a webinar session, because I can showcase many different etiologies that you can get to understand when you face your real patients. You can understand how to differentiate between the different causes. Most of the time during a hands-on face-to-face workshop, most of the time we select the easiest case to demonstrate. We usually would not select a muscle case for a tear trough injection, right? Okay. So I think tear trough is the only indication that is good to be taught over a webinar. Okay. So this is a good way of showcasing. Okay. So another case, okay, just have 5 seconds to 10 seconds. Ask yourself, what is the problem under the eye? Is it a tear trough, eye bag, muscle, okay, or combination? Okay, you have to tell within the first 5 to 10 seconds when the patient walks in. Okay, so this patient, very young, without any previous injections, without any previous surgeries, she had a little bit of eye bag, a bit of muscle problem, and a bit of tear trough. So it's a combination. Okay, let's try again. 5 seconds. 5, 4, 3, 2, 1. This is obviously a back problem, a fat problem. Okay, so this is a surgical indication to get rid of the depression as a result of the eye bag above that. Okay, so let's talk about a bit on a systematic approach to how you inject a tear trough using a cannula. Okay, so first step, okay, assessment. For me, there are 3 steps: look, feel, and move. Okay, so look at the depression and to decide the etiology. Sometimes it's not easy, so you have to feel with your hands. Sometimes an elevation could be a result of previous injections or previous surgeries, previous fat grafts. Okay, so feel for any foreign bodies, any lumps and bumps. Okay, and then there's a very useful test you should do. Is what I call the push-up test. The push-up test is to simulate the result you're getting after a filler injection. Okay. Second test is a snap test. The snap test is very useful to assess the skin quality. Okay. If you encounter a very loose skin, it takes more than 2 to 3 seconds to rebound, to come back down. You know that you have to undertreat that case to avoid any lumps and bumps. Okay. Snap test and push-up test. Okay. And then you will have to direct and decide the entry point of the cannula. Okay, just let me go back a little bit. So the entry point, for me, I will always use a 23 gauge needle because the cannula I use is a 25 gauge, 3 centimeter below the lateral canthus, vertical line. Okay, so need the angle of the needle, you have to go at the same angle with your cannula, which you will go in later on. Imagine if your needle going in like that and your cannula go in at a different angle, you're not going to go through. Okay, you're going to create trauma to your patients. Okay, so entry needle, clean puncture in and out. You do not need to stretch your skin with the needle, no wiggling with the needle. Okay, and then 25 gauge cannula going in. Aim the cannula or angle your cannula towards the tear trough area, towards the target zone, deeply on the bone, under the muscle. Okay, so the feeling you will get will be having the muscle on top of the cannula. Okay, and in order to confirm the layer, you lift your cannula to check whether you're at the deep plane. Imagine if your cannula is at the deep plane, you have the muscle, fat, and skin above. When you tilt, you do not see the shading of the cannula that easily. But if you are into the superficial layer by mistake, when you tilt, there's only the skin on top. Okay, so you will see the cannula very easily. Okay, so tilting is a good way of reconfirming the layer your cannula is at, especially to beginners. Always inject into the deep plane. Okay, so this free from tilting, what does it mean? That you do not want your cannula to tilt. You do not want to see any puckering to your skin. So your cannula is a natural, relaxed position to reconfirming whether you're injecting into the right region. Okay? And then inject 3 points. Okay? By using a cannula, you do not always need to do retrograde fanning. Most of the problematic cases that I've seen from doctors, they over retrograde fan. Okay, so as a result, you have product at places that you do not want. So with a cannula, you can inject boluses, okay, into 3 different points. One at the medial canthal line, second bolus at the medial limbus, third line mid-papillary line. So by placing 3 different boluses, okay, small volumes, and then gentle massage, you get a very even result to your tear trough treatment, okay? So this is a systematic way that I like to teach beginners to tackle a tear trough, all right? So that's my sharing. Thank you.
Hi, Dr. Inaka. We pass the floor over to you now. Yes, over to you, Dr. Inaka.
Okay, so it was such a thorough presentation by Dr. Ray. And thank you so much for the opportunity now. I'm going to share my presentation. And yeah, now I am on a presentation mode. Okay. Hi, everyone. Ray has decreased my job by telling all the tests of the assessment. So I'm going to share with you about more to the Southeast Asian patients. And since Indonesia also is one of the Southeast Asian with a very a lot of variety in ethnicity. So I'm going to share about the approach, the assessment to our patients, which has a very distinctive features each and every patient. As you can see here in the picture, there are a lot of there are 5 women from age 30 to 50. They have a different ethnicity features. These are all Indonesian patients. One with a rounded eye and a slim face, oval face shape, a very Indonesian face, and also the second picture and the third picture with Indian descendants. The fourth lady here, she's like 50 years old something, and she has a full mid-face area. And I'm sure that this is also what you encounter in your clinic daily. And this is one of the most challenging case. And the most right one is also a Chinese descendant patient with also quite full mid-facial area. So before we get into the injection, every time I do assessment, I always assess together with the patient. Like I ask them how they feel, what is the most important areas that they want to improve, what matters most, because sometimes what patients see might be different from what we doctors or we practitioners see on their face, what is like important, what should we approach initially. Because sometimes patients thought that when we're doing the approach indirectly, as Dr. Ray mentioned earlier, sometimes we need support from the mid-facial area. They might be confused if we didn't tell them what are lacking on their area, on their face area, and what needs to be approached initially before we get to inject the tear trough or correct the tear trough area. And this is one thing that I want to share with all of us injectors, that sometimes what patients see as what we see as a lack or something to be improved, actually some patients see it as something that is positive. Like this, I found it in one of a blogger. They say, so this blogger said that one thing that she likes about her eyes is actually the dark pigments and which is also included in the tear trough. So it is very important to assess together with your patient in my practice. Some of the tear trough assessment has been discussed by Dr. Ray previously, so I will just go briefly. This is one of taken from a published journal. Of course, take a proper pictures of your patient from the frontal view and also lateral and oblique view, and tell the patient to smile. By smiling, it helps us to see if there is any bulging on the mid-face area, and also on the orbicularis oculi muscle, because sometimes the bulging of the muscle, as Dr. Ray had also mentioned previously, it may actually, it is the area that you don't want to treat. And I will later show you bulging of the orbicularis muscle and also the midface area that is going to be disaster if we are injecting that area to improve the tear trough. And here I'm showing you the snap test as previously stated by Dr. Ray. This is the example of a mild laxity of the skin snap test. And for patient with this mild laxity, we should improve the laxity of the skin before we start injecting the tear trough. Because if the laxity persists there, you are going to fill in a bottomless bottle or a bottomless bag. That is my opinion. And this is a smile test. If you see this patient, she has a little bit bulging right underneath her eyes, and then she wanted to improve the groove, like immediately underneath the bulging there. And when we asked her to smile, this is what we get. There you go. So there is a bulging there, which is actually it is a previous injection. So it is very, very important to choose the right product and do the right technique and know the anatomy, which layers we should put our product with the right technique, of course. Now I'm getting into the case study. So this case study, she is a female, 29 years old, and I think she has a good mid-cheek areas, and her problem here is tear trough. And when we did a tilt test, it is a little bit positive, like a laxity under a mild laxity. And we can see by tilt test, what we can see is the more marked tear trough area, especially the medial part. And when we see the picture, there's a little bit slight under eye hyperpigmentation, which we encounter a lot in our practice in Indonesia. So what I did to her is injecting only Redensity 2, the non-hygroscopic filler, especially made for the tear trough. And the right eye, I injected her with cannula 0.5 cc, and for the left eye 0.4 cc. And there is a very marked improvement of her tear trough without doing any indirect approach by midfacial injection. And this is from the oblique view. She got a very marked improvement only with Redensity 2 without any midfacial injection because she doesn't need that. And then the second case here, female, 34 years old, with assessment, we see a mid-cheek volume loss, tear trough, and quite obvious eye bag. And then doing snap test, we didn't find laxity. So this is the result after being treated. Now, later, I'm going to ask Dr. Ray and Dr. Tahera what will their approach would be. So in this patient, what I did was I did an injection with RHA4 on the mid-cheek area only, the right cheek and both 0.6 cc. And with RHA4 without Redensity 2, because Redensity 2 at that time, I didn't have it at my clinic. So by RHA4 only, at the right layer with the right amount and the right anatomy placement, it can give a tear trough improvement. This is what we call as indirect approach by supporting the midfacial area to give improvement to the above anatomical area as you know here as tear trough. So case study number 3, female, 27 years old, and the assessment and the midfacial area. There's early midfacial volume loss, especially the soothe area and under eye dark circle. I think for this case study number 3, I thought that this case is quite not so complicated. Now, as we see here, actually the tear trough, it seems that it is not completely corrected, but when we see it from the oblique side, it is corrected quite well. But because the under eye dark circle it is something like genetic, so it seems that the tear trough hasn't improved so much. That is why it is very important to take oblique view from our patient's picture, because when they see mirror, mostly they are going to see it from the frontal view. So in this patient, what I did was injected ultra deep on the mid face area and superficially with our HA3 on the medial cheek, on the superficial fat pad on the mid face area. And for the tear trough, I only injected 0.3 cc for both eyes, 0.2 on the right side and 0.1 on the left side. And then this is a case study number 4. Actually, for this case, I wanted to refer her to Dr. Tahira maybe to do a surgery. However, she refused at that time because she didn't have time for the downtime. So by assessment, you can see that she has a very fullness on the mid cheek and also a quite prominent eye bag, especially the left side, and also bulging right underneath the lower palpebral area. So I tried to manage to inject her with hyaluronic acid fillers with TEOXANE range. What I injected her was I inject ultra deep at the soothe, both right soothe and the left soothe, 0.3 and 0.3 cc. And also at the deep medial cheek fat pad, the right side 0.2 cc and the left side 0.3 cc. And for the tear trough, the medial tear trough, I injected her with Redensity 2 on the right side 0.4 cc and the left side 0.5 cc. And this is case study number 5, female, 43 years old, and she had a post-lower eyelid blepharoplasty, and there's a mild hollowness, which presented as a tear trough, and a slight mid-cheek volume loss. And the approach for her is, as you can see, that the tear trough has improved. So what we gave for this patient, similar as the second case earlier, that I did not inject the tear trough directly. What the approach that I did was support the mid facial volume loss with ultra deep on the deep fat compartment and also on the laterals too, and superficially with our HA4, both on both cheeks on the superficial fat pad, by giving the right product on the right anatomy plane, and also with the right with the proper technique. Which one should you put on the periosteum? Which one you should put on superficial fat pad? We can get an improvement in tear trough even without touching the tear trough area at all. So this is another important thing that we can try to put in our practice after injection, make the patient a recording of the patient moving their faces, so we can see that the products that we give them did not give lumps and bumps, and all of them are natural, since we are using a combination of a strong filler to support and also a dynamic filler on the superficial area that gives natural result for our patient. So I think that's all that I can cover in this webinar. As a conclusion, assessment and knowing the anatomy is important, and also approaches might not be needed to approach directly for a tear trough. We should understand the aging process, what we need to approach first to treat the tear trough areas. And choose the right product is very important to get a natural result. And skin quality is also important to improve if you want to start injecting it or improving the tear trough. And multimodality might be needed to achieve optimal results, as we saw the patient number 3, the Indian descendants, that the hyperpigmentation sometimes can give an impression like an uncorrected tear trough. Thank you so much. And this is my contact. You can reach me from these contacts. And I give back to Jacqueline. Thank you.
Thank you, Dr. Inaka, and thank you, Dr. Ray. And I believe we have Dr. Tyra back. Dr. Tyra, are you online with us? Hi, Dr. Tyra.
I think Dr. Tyra hasn't unmuted.
There we go. Can you hear me now?
Yes, I can hear you.
Okay,
yes,
let's go. Let's see if we can get this going.
Yeah, so unfortunately, Dr. Tyra, we lost you right where you were talking about the Burton's grading for the tear trough. Yeah. So if you could finish with that, and then and stay online, everyone, for Dr. Tyra to continue with the complications aspect of treating tear trough.
Fantastic. I'm going to just go through Barton's tear trough grading scale again. So 0 is no tear trough at all, medial or lateral. Grade 1 is a medial groove. Grade 2 is a medial and lateral groove. Grade 3 is medial lateral with a notch where the medial soup has been completely lost. And I added to that myself with what I called a Bajani tear trough grading scale, where if you get a hollow between the demarcating the cheek, we call it separation of the malar fat pad. You call that a grade 4. And I'm going to demonstrate that on some pictures. So this is a lady in her 60s. She has a medial groove, so she's at least a grade 1. She has a medial and lateral, so that's definitely a grade 2. She has this gap here. This is where medial soup is lost. Remember, medial soup sits here. So her medial soup is lost. Grade 3, it's separation of her malar fat pad because deep medial fat compartment has been lost. This is a grade 4. And we just filled her deep medial fat compartment and the base of her medial soup. We did not treat her lateral or her medial tear trough directly, but you can see by filling this bit, you get improvement on both sides. Lady in her 50s, again, she's got full grade 1, grade 2, and a notch there at grade 3, a little bit of separation. Again, we filled her midface only and the base of her medial soup. Her lateral and medial tear trough have improved. So going into the next decade down in 40s, exactly the same treatment, except in this case, we also treated her lateral tear trough to blend between her cheek and the outer dip. And you can see that's a very youthful curve that you get. When you fill the lateral tear trough, it stretches the medial tear trough. So you get significant improvement of the medial tear trough. This is what a genetically Asian tear trough looks like. So you can see this deep groove in a 39-year-old version of myself. Deep medial fat compartment. So already in your 30s, if you come from this sort of heritage, this is what happens. Okay, this is a picture of me having been filled several years later. Okay, so it shows you that this fill is more important than this fill, and certainly doing it in the right order keeps it looking reasonably natural. We're going into the young Asian girls now in their 20s. With the fluid-filled bag. Now, it's interesting, as a surgeon, we often used to get referred these patients because fluid-filled bags equal surgery in a lot of people's opinion. But actually you can use, if you're experienced, dermal filler to draw fluid away from the area. This is what we did in this girl because she was not, her parents would not let her have surgery. So we treated it with a dermal filler, and we used filler in the outer aspect to draw the fluid away. And you can see she's had a very good result. It was very interesting hearing Dr. Ineke talk about the color changes. Bear in mind that if you lift the skin out, the pigmentation in the groove will improve. Pigmentation on the cheek will not. Cheek pigmentation here is sun damage. Pigmentation here is usually friction from the fold in the skin. So if you relieve the friction on the fold in the skin, the pigmentation improves. But where you lift the skin further to the sun, you'll just get more sun damage. They need sun protection. This is the most important part of treating an indirect tear trough. Filling the cheek and blending the outside. And it's always about filling the medial cheek before the lateral cheek. Otherwise, you end up with a ridge, and it's very hard to do this. If you fill the lateral cheek first, you end up with more gap that you then have to address. So I'm going to go straight on to the complications and what happens if you don't follow a good systematic approach. Okay, so personally, I leave medial tear troughs to a second treatment, and I only treat them if the indirect and the lateral doesn't work, because this is not an area that naturally has that thickening. And if you put filler there, especially if you put a sausage, I like the fact that Dr. Ray said that you use droplet, droplet, droplet. Droplets are much more safe than sausages. And of course, he was absolutely correct about keeping them in the deep plane. So this is a good approach. If you're going to use a needle, you can come all the way up to there. No needles in this area where we know that you may run into difficulty. This is my kind of technical approach: mid-face before tear trough, medial mid-face before lateral mid-face, medial sooth before lateral sooth. Okay, and the medial tear trough is the very last thing that we do. And you pick the right product, because if you don't stick to this, if you stick to it, you get a great result. If you don't stick to it, this is what's going to happen. So I'm just going to talk about the assessment. So this is an elderly lady with fluid-filled bags who did not want to have surgery. That same technique that I mentioned on the young girl we used on this older patient. And we put filler on the outside to draw the fluid away. Can you see? So this is what we call festooning, where the fluid sits in loose skin. Now, if you do this on a patient with tight skin, you don't get this draping of the skin, but on loose skin, you will see it as a festoon. This lady preferred the festoon to the bag, and about 6 months later, the festoon settled and she still had really good improvement of her bags. So these are things that you can do, but you need to be very experienced to be approaching loose skin and fluid in this way. Poor techniques give you poor results. So filler too close to the surface, filler too close to the surface, you get the grey effect of Tyndall. Okay, I get referred patients from all over the UK to undo these terrible messes. This lady had her medial tear trough and her lateral tear trough has not been touched. Can you see? And someone has just continuously tried to fill her tear trough without addressing any of the other issues. Okay. Migration is a really interesting thing. Bear in mind, orbicularis oculi is a very big muscle. So even if you put filler in the lateral aspect of the cheek, if you sit above the muscle, over time, the movement of the muscle, which is upwards and inwards, movement of the muscle will take the filler from here and bring it over to here. So this lady had filler in this part of her face in 2015, and it ended up here by 2016. Her tear troughs have never been filled. So please be very careful in that superficial plane that if you put something near the eye, I still use relatively soft products here, because if they do migrate, if you are unlucky, if you use something like Redensity 2, even in the subdermal plane, if it moves, you won't run into too much difficulty. Okay. If this particular patient had her product but deep in exactly the right place, except it was the wrong product. She had an expansive product. She had 0.2 put in her medial tear troughs, but it was not Redensity 2. It was a more hygroscopic product that is normally used for other parts of the face. And within 2 weeks, because she was young, she had good lymphatic drainage, she had good hydration of her skin, she ended up with 2 bulges that needed hyaluronidase. Okay, so this is why product choice is as important as product placement. We know that we have answers to this now, hyaluronidase, and we have different protocols depending on whether we're doing a cosmetic correction or a vascular emboli to the skin or a vascular emboli for visual loss. We're talking mainly about cosmetic outcomes today, but if we get the opportunity, we can always talk about protocols for emergency use also. This is that lady I showed you earlier with the filler in the wrong place. 3 minutes post hyaluronidase, you get at least a 50% improvement in tissue expansion. If you don't choose the right product, you end up with products that don't move with the face. Right at the start of this talk, I mentioned that if you're going to go in the subdermal plane, you need a product that moves like superficial fat. And this is what happens when the products don't move like superficial fat. So from my point of view, the range of products that we have from TEOXANE goes through every layer, and you can have a product that is specific. If you want a deep fat substitute, you can use RHA4. If you want a superficial fat substitute, you can use RHA3 or 2. If you want an epidermal substitute, you can use RHA1. If you want a bony substitute, you have ultra deep. And of course, Redensity 2 is your non-hygroscopic, non-water drawing product specifically for the tear trough. When we do it correctly, we don't have to worry about how it's going to look. You can do countless things at different levels of the face, different parts of the tear trough, lateral, SUV, medial SUV, mid-face. Her medial nasojugal groove has not been corrected, but holistically she looks superb. I'm hoping that my bandwidth, whatever happened to it, will sustain a question and answer session. I'm going to put my video on and hopefully can see you and talk to you properly.
Hi, Dr. Tyra. Yes, we are able to see you now. If you would, hi. Yes, and if you would share your screen, so we'll be able to see Dr. Ray and Dr. Inaka as well. At this time, for the next 10 to 15 minutes, we would allow the three of you to interact with each other, have a very engaging discussion about tear trough, the differences between the patients that you see, Dr. Tyra, at your side of the world versus Dr. Ray and Dr. Inaka, and to share with our audience what are some of the pearls that they have to take back with them today. Over to the three of you.
I just wanted to congratulate my two non-ophthalmology colleagues on their superb tear trough results. They're really quite impressive. Well done.
Well, I have a question. I'm sure you see a lot of cases with dark pigmentations, especially the Indian ethnicity. So do you see, apart from the depression improvement, do you see a lightening with the Redensity 2, with the dermal restructuring complex? Do you see a lightening effect from the Redensity 2?
So because I place Redensity 2 deep to the skin, the other molecules that are in Redensity 2 won't have a dramatic impact on the surface. But if you lift the concavity, you take away the shadow, and the skin is folded when you have a tear trough. The friction of the skin gives you a post-inflammatory pigmentation. So they have a color, which if you lift and it is exposed and not sitting in a groove, over time the color improves. And I usually also add in a skin lightening product, which is useful. I also usually tell them to wear sun protection so that the freckling of the skin on the high point of the cheek, which on the Indian subcontinent, that is where they get the most sun damage. They're freckling all the way here, and it adds to the darkening effect. So I get them to wear sun protection, I get them to wear a lightening product. And TEOXANE do a beautiful under eye product that has light reflecting particles in it. So that's a very nice thing for them to finish off their skincare with. We often forget about skin because we're so busy concentrating on the deep and superficial layers of the underside. Who doesn't want beautiful skin? That's ultimately so that skincare, having good products for skincare is really important.
Cool. Yeah, I think that's very interesting because I advise my patients together to use Redensity 1. So I spare a little bit on the periobital region. So apart from the face, you do that. I can do the upper eyelid as well. So I see a lot of patients with darkness, especially with repeated all these makeups and all that, they get some pigmentations over the upper eyelids. So Redensity 1 works beautifully.
Jen, do you use Redensity 1 in the periocular area?
Yeah, so I think Redensity 1, it helps a lot of problem on the periorbital area, especially the eye area. Like I'm quite a skeptical person before. So before I try a product, I really want to see whether it works because of the product itself or because I combine it with other modalities. So I tried in some patients only with Redensity 1. The patient is very satisfied with the result for the under eye dark circle. And I think it is also because the skin quality is improving after the Redensity 1 injection on the skin. So it helps when the collagen improves, it helps to give a glow on the skin. Yeah, but I think that is my take for the Redensity 1.
And what I often say to patients is something that we didn't know when we first started injecting fillers 20 years ago, that when hyaluronic acid in your skin protects your dermis, it's part of its function. So if we replace the hyaluronic acid, even if it's not cross-linked, even if it's just a skin booster like Redensity 1, for the period of time it sits in your skin, it actually makes your skin metabolize more efficiently. And if you were to put Redensity 1 on the whole face and go out in the sun without sun protection, the hyaluronic acid will absorb the free radicals before your skin does. So there is a protection given to you simply by putting filler in the skin. So in the UK, where we have people who just sunbathe all the time, we often do a course of Redensity 1 a couple of months before the summer, so then they can go out in the sun and bare their chests if they really need to, or bare their skin and the HA will degrade quickly, but their skin will not. It's a kind of a different approach, but that's something that I often sell to my patients in this area. There's not a lot of things you can do in this, but Redensity 1 is one of them.
Yeah, and I think the result is also faster than giving a pigment laser for treating the under eye dark circle. That is what I discovered from my practice. Like injecting Redensity 1 really gives a marked improvement on the under eye dark circle
because it gives some skin thickening, so you don't see the color of the dark tissues underneath. So they all contribute differently. Redensity 2 lifts the groove. The lifting the groove stops the pigmentation from the rubbing of the skin, and the Redensity 1 thickens the skin so you don't see the color of the tissues. So you're ticking all three of those boxes of what contributes to that darkness under the eyes. I can speak with feeling from that Asian subcontinent and you saw my pictures of my dark circles, that it's actually liberating not to have to wear concealer every day.
There are a couple of questions discussing Redensity 1. Maybe we shall spend a little bit more time on this. One question pops out about the volume that we use for Redensity 1 under eye. So for me, I inject very little. So for each eye, about 0.2 to 0.3 cc, very, very small droplets intradermally or subdermally. The problems I have encountered, if you inject over 0.3 for each side, you get really bad swelling sometimes. And sometimes for a lot of punctures, you get really bad bruising. So the bruising is actually worse than the pigmentations itself. So for me, I'll limit to 0.2 to 0.3 cc on each eye. How do you guys do it?
I put maximum 0.5 across the eyes and 0.5 elsewhere. Not dissimilar to you. So half a syringe for around the eyes and half a syringe quite often in the perioral area, because it's giving people improvement to their skin in those highly mobile areas where you don't want to bulk up the tissues.
Yeah, I think 0.2 to 0.3 cc on each eye for Redensity 1.
And there is a question on the upper eyelid. I always use a needle, a very small one, maybe 32 gauge or even 34 gauge, because you do not want to inject too deep. Otherwise, you're going into the orbit. You don't want to puncture the eyelid all the way. So for me, the target layer would be the dermis on the upper eyelid, very, very small droplets. So needle, micro droplets, just all the way along the upper eyelid. Do you guys do the same?
I use tiny droplets. I use the needle in the box. I don't use a smaller needle. And I just stretch the skin and just bury the bevels. So you are in that very superficial layer. Absolutely.
Yeah.
There is bear in mind, there is downtime with Redensity 1 in around the eye. You can see where it's gone. It's not like a treatment where the patient walks out looking perfect. There is evidence of where you've been, and you must warn the patient they're going to look like that for a couple of days.
But they love it very much that they will come back again for, another session of like having, yeah. I only do on the orbital rim for skin tightening around the eyelid area. Sometimes I use other modalities, like machines.
For sure.
Dr. Tyra, can I ask? We gather questions from the audience, or can I ask a question about the case that I presented earlier? Because the fourth case, the lady, the 53-year-old lady, like the one had already full fullness on her mid-face area. If she came to you and Dr. Ray, what would be your approach for her?
So the interesting thing about having a full face, there are two layers of fat you need to think about, the deep and the superficial. Usually in your 40s and 50s, your deep fat layer has been lost. But if you have a little bit of superficial fat, it disguises it. Your face is like a bed. If the mattress and the base of the bed have shrunk, but you have a big fat quilt on top, you can't see it. Okay, so this is actually what happens. So that fullness is not structural, it's superficial. Okay, and I think what you did, if I remember, is you put ultra deep in the deep layer, correct?
Yes.
So this is why it actually worked quite well, because you were sensible enough to know that actually she still needs structural support. She had the shape of her face was not great, even though the skin was well supported, because you've got a big fat quilt over a shapeless base of the bed. So you can actually often palpate where the volume loss is better than you can see it, and you can put it deep. Personally, I tend to use RHA4 rather than ultra deep, even in down on bone in this area, because the muscle is very thin and the muscle is very mobile, and sometimes product can filter through. those fibers.
Mm-hmm.
So I tend to, in the soup, use, if I'm going to, I either use Redensity 2, depending on which part of the soup, but if I'm going into the, even onto the bone, even if I think I'm on in safe ground, I still tend to use RHA4 just in case, because I only use Ultra Deep where I want to substitute bone, you know, bony prominences. Soft tissue prominences, deep fat substitute RHA4, superficial fats substitute RHA3 in my practice.
Thank you, Dr. Tyra. Dr. Ray, what would be your approach for the patients?
Well, I think my approach will be very similar to yours. I agree you need some deep fillers, but you need a strong but not too firm to create lumps during its expressions. So it was a brave move to use Ultra Deep for that particular patient. You have to judge the volume very well. If you do over-inject for that particular patient, she's going to have a very stiff upper mid face. So sometimes it's not very pleasant for the patients when they smile, or they will feel something is pressing against the muscle underneath. So yeah, very good result. I would probably use RHA4 rather than, I'm not as brave as you. So
but the result, the thing is that it's what sits well in your hands. Your result was superb.
Yes, exactly.
Thank you.
I see a question from Dr. Henry. Dr. Henry, how are you? So, must be a difficult question. Let me see. So, Dr. Henry sees several cases with a lump of filler after several months of tear trough filler injections. So, he's asking whether we have experienced with time, the muscle pushes the filler migrate to another part, and any tricks to prevent this from happening.
100%. So one of my biggest issues with nasojugal cannula treatments, definitely sausages, but even with droplets, this is not an area that normally has any fat. And we are putting filler, even if it's deep, in an area where the muscle is actually quite tight on the bone. We're squeezing it into the deep muscle fibers to give it support, because we can't do this. We're doing this. That's fine. Be warned, over time, the motion of the orbicularis oculi, that is its mode of action. Lymphatic drainage, pushing the tears. Anything that is sitting here will end up here if it is above the muscle. Even if it is deep to the muscle, if it filters through the fibers, it will come to the superficial layer and it will end up here. So you have to be very careful about quantity and about product choice in this area, even if you're going deep. And of course, if it migrates, once it gets here, there are very few natural hyaluronidases sitting where there is just skin and muscle, because natural hyaluronidases tend to be in more abundance where there is subcutaneous fat. There is none here. So once your filler collects here, you say, let's wait, it will go away. It's going nowhere. 2 years later, it'll still be there. 3 years later, it'll still be there. Your only option is to use the hyaluronidase and be more careful next time.
My tip would be under inject, don't over inject, because for most of the cases that I see would be you put a large bolus under the muscle, and as Dr. Takira said, with time the muscle pushes the filler either medially or pushes the filler through the muscle fibers into the superficial plane. So under inject, sometimes you just have to accept not all of the depressions can be filled. You have to accept this degree of depressions and to avoid these kind of problems from happening.
There's a question on the panel that's saying that, can the doctor show us more things that are not suitable for filler? You know, if there's no improvement on push-ups test or very little improvement, what would you do, Jane?
Which question, doctor?
There's a question on my chat that's saying, if patient has no improvement on a push-up test, does that mean you wouldn't fill them?
So if I think from my opinion, the push-up test on it, for me, it really, really helps because when I do it, it really didn't give a marked improvement on the patient. And I don't want to give a over correction because so yes, push test really is something that we can use as a tool.
And
for me,
what
yes.
would you say, Dr. Ray, if the push-up test shows very little improvement, is that an absolute contraindication to you for TEOXANE? Would you think, okay, there's no need to put any filler there?
Well, I think firstly, you need to decide how come there is no improvement in the push-up test, because you have to take in the history before your assessment. So follow the basic principle from the medical school. History taking first. Always ask the patients if there's a large lump of filler in the mid cheek. If you do push-up test, that's not going to move a lot. Okay, so a negative push-up test could be due to previous injection or previous surgeries. I see a lot of patients nowadays with repeated threadings. All the subcutaneous fat just stuck together. You cannot move it, basically. So that gives you a negative push-up test, but it does not necessarily mean the depression under the eye is not suitable for filler injection. Okay, so first of all, start with history taking, and then feel the mobility of the plane that you're going to inject. Okay, so I think these two are the most important. Yeah.
That's such a good point. Patients don't tell us, bearing in mind dermal fillers, my own practice has been around for 20 years now. So patients don't tell us. They think I had it 6 years ago, I had it 12 years ago. You say, have you had any fillers in the past? No. They don't think it's relevant because it was so long ago, right? But I've just said, in some parts of the face, the filler is still there years later, and they really don't think they're lying. They either forget or they don't think it's relevant. So pushing them for a history is so important. That's good medicine. It's not just good aesthetic medicine, it's good medicine.
Exactly. So that's why I love to use cannulas for my injections, because without pushing the filler through, you are using your cannula to test what kind of environment you are treating within the plane. So if you encounter a lot of resistance while maneuvering your cannula through, you know that there's something wrong. Okay, so you have to stop before your injection. You have to ask the patient again, what have you done? As you have to drill in the history. And then I encounter those cases every day. Ask them, what have you done? Nothing. No injection, no surgeries. And then the cannula, impossible to get through. And they start asking, what have you done? And then she goes, oh yeah, I remember. I have something done. It's typical scenario that we face every day. I hate it.
Absolutely.
Thank you, doctors, for the very lively discussion. Thank you, Dr. Ray, for pointing out, most of us, when we come to see you, we would like to try to think that we look our best without anything in our face when we see such a, such a good-looking doctor like yourself. But anyway, yes, it is amazing how, we've been talking about periorbital area for so many times. TEOXANE has had so many campaigns around it, but yet every time when we talk about this, there is endless questions and endless insights that we can share. And it's amazing whether we have Dr. Tyra from UK, Dr. Raymond from Hong Kong, Dr. Inaka from Indonesia, but there are commonalities among the doctors. And one of it, I would say, is the TEOXANE approach. Really know your anatomy, choose the right technique, and of course, choose the right product. So I want to thank our three doctors for spending their time today with us. But before I let you go, and I always do that to our panel of doctors, every one of you should give 1 point for our doctors to leave the webinar with. So let me start with Dr. Tyra. If you could say one thing that you want our attendees to leave this webinar with this evening, what would that be?
If you insist on doing a nasojugal groove with the cannula, droplets, not sausages. Droplets, not sausages.
Okay, we hear you. Droplets, not sausages. That's a nice one. Dr. Ray?
I think the take-home message, one of them would be history taking and assessment is equally as important as a technique.
Okay, so history taking and assessment, which is actually the topic of our webinar today, right? How do we ensure patient satisfaction assessment is very important. Dr. Inaka?
Okay, so I think my take is going to be if we are going to make it perfect by also getting a good skin quality, improve the skin quality as well before injecting the tear trap.
Fantastic.
Okay, so I'll do a quick summary. Droplets, not sausages. History taking and acute and sharp assessment from Dr. Ray. And finally, don't neglect skin quality. And on that note, I want to do a little promotion on the 5th of October, which is a few Wednesdays from today. We're going to have a webinar on skin quality. So for all of us who are still on, please remember to sign on and watch it. But for today, periobital gets the time to talk about. But you know, it's the beginning, it's not the end. We haven't learned everything yet, and we'll continue to have such sessions. And I hope that doctors will continue to join us. And I hope to also continue to invite our panel of TEOXANE experts from UK, Dr. Tyra, from Hong Kong, Dr. Ray, and Indonesia, Dr. Inaka, to continue to share with us your insights and how you are doing, how you are building up and improving the practice on the periorbital area. And with that, the last slide we want to show everyone is that we do have the TEOXANE APAC app. And if you would take up your phone right now, you could scan the QR code and you'll be able to download a lot of materials within this app for your learning as well. And for some of you who have indicated that you've missed the beginning of the webinar, do not worry. You will get a replay link in your email in a couple of days when we close this session. You will receive it in your email. So with that, I want to thank everyone who stayed with us online. Thank you, doctors. And I hope to see you very soon in person, especially Dr. Ray from Hong Kong. And yes, and see all of you 5th October for a webinar on skin quality with live injection. Thank you, everybody, and have a good evening.
Bye.
Wow.